Okay, let us start.
Yeah.
Ahmedabad Hospitals and Nursing Home Association invites you all to this AHNA Knowledge Series webinar. Today, we have a special webinar on COVID and specialty in medical fields. I will start with some lighter note and lighter tone. Corona. Somebody asked Saif Ali Khan, some media person asked Saif Ali Khan that what is your opinion regarding Corona? तो सैफ अली खान ने बोला मेरे को करीना और कोरोना दोनों एक जैसे लगते हैं। कि बोला करीना से मैंने जब शादी की थी तब मुझे ऐसा लगा था कि मैं उसको एडजस्ट कर लूंगा और वो मेरे से एडजस्ट हो जाएगी, बट जैसे अनुभव मालूम पड़ा तब मेरे को लगा कि अभी मेरे को उनसे एडजस्ट होना पड़ेगा और ऐसे ही लाइफ निभानी पड़ेगी। तो उसने मीडिया वाले ने पूछा तो इसमें कोरोना के साथ क्या उसका ताल्लुक है? तो कोरोना का भी ऐसा ही है। कोरोना का जन्म नवंबर महीने में वुहान शहर में हुआ। तब सबको ऐसा ही लगता था कि हम उसको कंट्रोल कर देंगे, लेकिन जैसे जैसे समय जाता गया, लॉकडाउन भी हुआ, लेकिन अभी सब देशों ने मान लिया कि उसके साथ हमको एडजस्ट होना ही पड़ेगा और उसके साथ रहने की आदत डालनी पड़ेगी। तो इसी तरह कोरोना का और करीने का जो ताल्लुक है वो सैफ अली खान ने अपने मुंह से ऐसे उसको बताया। तो यही टोन के साथ मैं ये आपका स्वागत करता हूं ये सेमिनार में। वी हैव टुडे moderator for this seminar is Dr. Sunil Mehta. He's a physician. Dr. Nitesh Shah, he's a pulmonologist. Dr. Sanjeev Haribhakti, he's a gastrosurgeon. Dr. Sanjay Rajput is a gastrophysician. Dr. Ashish Kausal is a medical oncologist. Dr. Chirag Amin is gynecologist. Dr. Yogesh Parikh is orthopedic surgeon. Dr. Kalbit Shah is a ophthalmologist, and Dr. Hasit Patel is a nephrologist.
Milan bhai aa gaya
Yeah. So with this, I hand over to Sunil Bhai Mehta to ask questions to all the panelists, and we will be able to see the expertise of all the panelists in the answers they are giving. Over to Sunil Bhai Mehta.
Thank you very much and good evening, everyone. Dr. Viren Bhai started with, he is a surgeon, and he started with a very light note of Karina and all that Corona and Karina. But in both the cases, you have to be safe. Like Saif Ali. So safe is a very important factor, and safety, and that's why we call it to cure or to control Corona, you have to have a SMS, social distancing, mask, and sanitization. If these three things you have with you, I think you will be able to control this very nicely, and I hope we're able to control this. Now we have come to a peak, and then probably now it will go down, and there will be the flattening of the curve. That's our hope. Whenever we are starting this, I would like to, I remember a person known as Edward Jenner. In 1796, he invented smallpox vaccine. He took a serum from cowpox virus or cowboy boil, and that he injected in an 8-year-old boy. And then he noted that yes, this boy did not develop smallpox. And that's how the idea came that yes, there is something known as vaccine and which can be prevented. I sincerely hope at the end of this lecture or this seminar, we'll be able to come to a conclusion where we come to a conclusion that we will be able to do something about the virus, and hopefully we'll be able to get our vaccines early. As you can see here, there are 10 people who are going to talk on this. So itself suggests that the COVID is a very, very varied, it has a very varied presentation, and it affects every single branch of the medicine. So it is not a domain of any one single branch. It affects everyone. Few days back, we did a seminar only on physicians and infectious specialists who were talking on COVID. Now, today we have thought of doing a seminar which involves everyone. That is gynecologists, surgeons, orthopedic surgeons, ophthalmologists, cancer surgeon, nephrologists, and things like that, and even a cardiologist. So let's start ball rolling, and I'll keep on asking the question. Since there are 10 people, I request all of the panelists to be very brief in that answer and to the point. Let us start with
Sunil bhai,
yes.
just a minute. I forgot to introduce two people. Dr. Ankit Chauhan is an anesthesiologist and Dr. Milan Chak is a cardiologist. Milan Chak will join shortly.
Yeah. Welcome to all of them. And now the first question goes to the surgeon, that is Sanjeev Haribhakti. Now there are two questions for him. How important is the elective surgery in this era of COVID? And how important is the emergency surgery in the era of COVID? So what will you do? Do you really insist on RT-PCR test and then only you operate the patient, or what is your strategy? How do you go about it?
I think that's a very important question because surgery is one very high risk area for transmission of COVID. So we need to be very cautious as surgeons. Yeah, at the moment, our policy is to do elective RT-PCR before all elective surgeries, not just before surgeries, but before all admissions also. We do RT-PCR test for all patients. There was a time in between when RT-PCR was not available. Government did not authorize us. That was a time that we used to, do patients. We used to postpone elective surgeries as far as possible, and we used to think that get over this COVID era and then we will operate elective cases. But now I think the realization has come that COVID is not going to go away in 3 to 6 months at least. So there is no point in postponing elective surgeries. We have to conduct elective operations with due precautions, with due consideration. So nowadays we have started doing all elective surgeries with all the precautions and the guidelines. So basically it starts from the triage at the admission area, just before the admission area at the hospital entrance. And then all the patients, there is a visitor restricted policy, all the precautions are taken. And before admission, we consider basically everybody, because we test only patients, we don't test the relatives. So we have all the PPEs and everything is there. But even during the hospital OPDs and during our rounds also, we are fully protected. In the theaters, we have complete coveralls and the gowns and the PPE suits. We take all the precautions in the theater. Anesthesiologists, they also take all precautions because that's also high risk area, intubation, extubation. The laparoscopic surgeries are especially at a higher risk because of the aerosolization. Even endoscopies, for that matter, Sanjay will talk about it. But laparoscopy is one area where there is aerosolization, so there is a risk of transmission. Even using a lot of energy sources that we use during surgery, like monopolar, bipolar, cautery, using energy devices like harmonics, which are ultrasonic devices, they also create a lot of aerosols. So these are some special areas where they should not be liberated freely into the theater. So they have to be, disinfected, and they have to be evacuated by special systems which evacuate the smoke as well as all these fumes that are produced during both laparoscopy and open surgery. So I think these are all the areas that we have to be extremely careful. Emergency surgeries, if they are life-saving and we cannot even postpone for 12 hours, and these situations are very rare in surgery, like trauma, massive bleeding is one, peritonitis where patient is very sick, then we would go ahead without the test. But many of these surgeries like obstruction and other, semi-elective kind of procedures can wait for 12 to 24 hours. So we would insist on a COVID test before we operate on these patients. At the moment, our hospital, we are not treating any COVID patients. So if the patient has a COVID positive, then we shift out to a COVID positive hospital. And we believe that COVID positive and COVID negative, there should be separate establishments, because we shouldn't mix these patients for the risk of transmission of the disease. Though there are certain hospitals where there are these mixed patients, but at the moment we believe that we shouldn't have mixed population, especially in a small healthcare organization like ours, where this may cause more increased risk of transmission of the disease.
So, Sanjeev bhai, one more thing, that supposing you operate the patient and after 3 or 4 days he develops all the symptoms of COVID and you get a COVID test done, which comes out to be positive, then retrospectively, what do you do?
So retrospectively, one is that this patient could be having a false negative test. That is number one. He would be in the incubation period. So most likely that would be the scenario. And it is known that after surgery, the precipitation of symptoms, if the patient is in the incubation period, is much faster and sometimes much severe also, because it's a second hit of the systemic inflammatory response. So they can go into crisis. The risk of their morbidity and mortality is also much higher if you operate in the COVID incubation period. And that's why it is much better, not just from the healthcare workers perspective, but even from the patient safety perspective, to test all patients before we take. Now your question, if the patients come as positive, then retrospectively we'll have to go and see what all protection we have done. If we have taken all the protection and PPEs, obviously that is one thing that we need to take. Second is, all healthcare workers, whether they are on the prophylaxis or not. That is also to be checked. If they are not on, they should be on the prophylaxis, because at our organization we have giving prophylaxis for all healthcare workers by hydroxychloroquine, and we continue it beyond 7 weeks, because though the guideline says, ICMR guideline says that only 7 weeks, but we have continued this prophylaxis for all of our HCWs. And we'll have to go in and see if there has been any exposure which is without protection. This exposure, for example, somebody has been in the patient's vicinity without protection, then obviously they need quarantine and they need to be tested if they develop any symptoms. So that is the policy that we follow. We will go back and check whether the exposure is with protection or without protection. That is very important. If it is protected exposure, then yes, it's okay. But if it is unprotected, then they will need quarantine. Initially, in the initial period, we used to quarantine many people, even though they had a protected exposure. But nowadays, I mean, it's not just possible with the kind of cases that are going up and, with the exposure that we are all having. I don't think we can quarantine all of our healthcare workers. Then there won't be anybody to take care of our patients.
Take care of it.
So then, yeah, so that's now our policy.
Thank you, Sanjeev bhai. Now we go up to Dr. Senior most orthopedic surgeon, that is Dr. Yogesh bhai Parikh. Yogesh bhai, I would like to ask you a question. That
Yes.
People say that yes, orthopedic surgery is a most aerosol producing surgery, and you people are more risk of developing COVID if you are not careful enough to during the surgery. So in a open surgery and a closed surgery, what all precautions do you take while operating the patient?
To be very frank, I also suffered from corona in a very initial phase. And retrospectively, if I see for myself, I had not taken much precautions and I got it through the patients only. But at that time, we were using the Rotomec mask, which is almost does not allow any this weight or aerosols to penetrate your mask. All other masks are not safe. Those who are using the mask, my advice is to change the mask every 2 or 3 hourly. Otherwise, if you want to go for the surgery, you should use a mask along with the face shield. That will make you little more safe.
Right.
And sterilization of the theater, fumigation of the theater, and the linen which we use should be almost impervious. So there are certain clothes which you can use during this surgery, and push all this linen to the warm washing with the warm water or the hot water, so you can eliminate the organisms from the next surgery for the next surgery also. The cold water wash is not enough. This is what I believe.
So another thing I wanted to know from you is, sir, is the closed surgery and open surgery same? Supposing you do a robot surgery in the knee joint and open surgery in knee joint, are the precautions are the same? if you are giving a block surgery, if you are giving a local anesthesia surgery, all these surgeries, the precautions are same or slightly different than the.
It is almost same. We use some layers to protect the skin, which we almost all the surgeons are using. Otherwise, I don't think the corona is spreading through the blood. If the blood touches to us, or that is not the media through which we get the blood. So we are not worried for this blood which we come in contact during the surgery. The only thing, the breathe from the patient or our colleagues, that can give you an infection. So for the surgery, I am never hesitant to perform.
No, I agree. But then the
Yes.
instruments which you put in,
Yes,
they require the same treatment,
same treatment, same.
like endoscopy and
Same.
the open surgery.
Now our protocol is that we wash them first with the regular water, then we use a formalin to wash them.
Okay.
Yes, and then again we put them into this electrolyzer, and lastly we wipe them with the spirit, and then we put in the cupboards. So this is the routine precautions we take for all the surgeries.
Okay. And disposable may be a good option.
Um, I doubt little bit, because the disposables, the sterilization itself is doubtful to me, because in which conditions they have sterilized and how long they were on the shelf, that we don't know.
Okay.
So,
Okay.
yeah.
Thank you very much, sir. Now, after listening to two big surgeons, let us go to the anesthetist who has all the secrets of surgeon with him. So let us call on Ankit Chauhan. Now, Chauhan said, what precaution would you take and would you expect surgeons to take while a patient of COVID comes to you for the surgery? And if they comes for the emergency, we don't know the status of COVID. Then what all things you will take care while giving the anesthesia?
Okay, fine. So COVID or no COVID, right now the time is like we have to consider every patient as COVID, even if the RT-PCR is negative, because they can be asymptomatic, they can be false negatives. Even the patient's relative, they can transmit you infection, even the staff around. So COVID or no COVID, there is no point now. You have to consider everything, everyone around as a positive, and take maximum full precautions, whatever you can take. So never hesitate or never stop yourself from using a PPE or a respirator if you are using, or an N95. So this is the basic standard which we use for prevention. That is number one. Number two, in OT preparation. So whenever you are taking any patient, COVID, non-COVID, emergency, elective, make sure that your OT has minimum staff, only the required much of staff. There has to be minimum movement in and out of the OT. So the person cannot come and out, and the aerosols are going outside, inside. That is number two. Number three, if you can make your OT negative pressure, that would be wonderful. Some corporates, they have. Nursing home, I am not sure we can do a negative pressure room. Number three, you can have a separate induction room. Or while induction, there are minimum people around, because the induction and intubation is the procedure where maximum aerosol generation is occurring. So minimum, like one person who is intubating, other is his assistant, and in case of any emergency, the third person is there. So minimum person at the time of induction. Surgeons or any extra assistant can come later on after the induction is complete and the patient is positioned. Number three, there are different methods to prevent the aerosolization. Like there are people who practice open theater concept. They keep the doors of theater open so that the airflow is continuous. Number four, different aerosol box which are to be covered on the patient, and the patient is fully covered on the all sides, and you do an intubation through the intubation box. So if the patient, by chance, if the patient is coughing, or you have to do some suctioning and all that, the aerosol which are generated, they only confined to the space area below the intubation box. Number four, if you can possibly do your surgery in regional, especially orthopedic surgeries, or some limb surgeries or peripheral surgeries, or you can do in spinal, the lower half body surgeries. So that would be better to avoid all the complications of aerosol generation. So these are the few things by which we can reduce the aerosol generation as well as the exposure. one thing I would like to suggest in the laparoscopy. So, as Sanjeev sir has said, there are some special types of filter, decompression system, and that to be used to deflate the pneumoperitoneum. So if you are not having that pneumoperitoneum, the special HEPA filters to deflate the pneumoperitoneum, what you can do is you can deflate the abdomen slowly into a bag containing hypochlorite solution. So, and everything has to be closed. Circuit has to be closed. You can use ICD bag in which you are deflating your pneumoperitoneum, and then ICD bag has to be stuck in the direct suction. The other thing which can be used is like a closed circuit system. If you are using in a private nursing home a main circuit, that is not good. You have to have a closed circuit system with a ventilator so that the patient and machine is in a single loop. Nothing is going outside in a normal air. And you have to have a scavenging system, or at least a tube connected to a scavenging port going outside the OD, so that the extra gases which are vented out to from the theater and the theater persons are safe. So these are some points which we can do away to minimize your exposure risk.
Yes, I agree with you, Ankit bhai, but this is the best platform to say something to your surgeons. Would you like to say something to the surgeon that they have to be very careful in this particular area?
I would suggest like those surgeons are working with an airway, like head and neck surgeons, ENT surgeons, or that matter, gastroscopists, Dr. Sanjay. So they all procedures are very much generating the aerosols because they are fiddling all the time. So these are the surgeries in which maximum precaution has to be taken. And at the outset only I said that COVID, non-COVID or type of surgery, you have to take maximum precaution what is available with you. If you are not having a precaution, then there are chances that these are the high risk surgeries from which you can get a COVID exposure.
Thank you very much. Now going to slightly on a lower part of the body, that is our gynecologists who've been waiting. I was told that gynecologists can wait for a long time, but nowadays they don't wait for a long time. They go CS very fast. So let us take Dr. Amin Sahib. He's our senior gynecologist. And I would like to ask him few of the questions. But before asking the questions, he has prepared some slideshow. I don't mind if he runs few slides. Amin Sahib, you can go ahead with your slides, please.
Yeah, thank you, Sunil bhai. We'll start with the basic thing. Just first, for a lighter note, that we have to protect ourselves. Actually, politicians and government is not going to protect us, because every time the scene is changing. First they say stay home, then they say go to work. And COVID is also telling that I want to thank all of those people who have done all the variety of blame shifting and hiding the real numbers and everything. So these are some of the nice cartoons. Okay, now we have to keep in mind that the army is actually lucky because they can see the enemy, but doctor is not seeing any enemy. So it's a fighting an unseen enemy. This is basically the doctor's risk, particularly that when we are wearing continuously the mask and now the respirators, there is carbon dioxide accumulation occurring to us. And because of that, sometimes even in OPD, because we have long OPDs, gynecology has particularly long OPDs, we are actually sometimes get irritable also because of the continuous CO2 accumulation, and you feel exhausted talking loudly. That is one thing. And during the time we are not able to take proper fluids, so dehydration is also one of the issue. So is it a role of group practice? I have been promoting this, that now we have to shift to group practice where we can shift our timings and we can reduce our work hours. So we have to think of reduced work hour as our new normal, basically. Adding the risk is the continuous contact of the patient in a closed room, in a consulting room. Our branch is a confidentiality issue, and privacy is of paramount importance. Because of that, we have to compulsorily allow at least one relative along with a lady patient. And most of the time, at least examination is necessary. So teleconsultation is not actually the answer, except it can be helpful in a follow-up thing.
Right.
And particularly in pregnancy, what is happening, that it is noted that the pregnant ladies have a suppressed immune system already. And this works as an advantage to us as well as little disadvantage to us. The biggest disadvantage is that there is increased asymptomatic carriers. So more infected patients who are infective to others and healthcare workers, but they don't have symptoms or very mild symptoms. This is the biggest problem in pregnancy. As soon as COVID came, it was identified, even at a LG hospital, it was identified that if they did test of 20 pregnant ladies, they found that 8 to 10 were positive without any symptoms. The advantage is that there are milder symptoms and there is less possibility of cytokine storm and its risk, basically. So we are not seeing too much patients who are having pregnancy with cytokine storm. That is the little bit of advantage. So protection is not easy, comfortable or cheap. Now what we do in our OPDs, we are using 3M7502 respirator with a shield. Shield is a great protection in OPD actually, and this is sufficient. But when we go for operation theater, we use 6800 with P99 filters. This filter has a coding. The red code, pink code is indicative of P99, that is a 99.5% coverage. And this is necessary because it covers all the aerosol. So shield along with the filter comes in 6800. This number is to be remembered. This is a good mask for operation theater, particularly laparoscopy. Now, what if corona infection occurs during pregnancy? There is no need to get panicky. The course of corona infection is similar in pregnant ladies as to the general population. Most of the time, there will be mild illness and symptoms will go away. But the fever can be detrimental to the fetus. So paracetamol is liberally used, tepid sponging is useful, and monitoring is of utmost importance. Our cutoff for, as Sunil Bhai will say, that cutoff for normal non-pregnant patients would be 92 saturation. But in pregnancy, we keep cutoff as 94. So after 90, if it is below 94, admission is advisable. So pregnancy does not appear to increase the risk of infection or severity. It has similar management if pregnancy with COVID infection occurs. If patient is not in labor, we generally avoid the labor process and allow 21 days to pass on until the patient will become non-infective to others and patient will be comfortable. Prolonged and difficult deliveries are not advisable. Pregnant ladies in house are also advised to have reverse quarantine. So they are in house also, they are little bit quarantined. And educated class understands this. So this is little bit helpful. We always test all the patients before delivery is due, because for the safety purpose of mother, as Sanjeev told, that if we have operated and by chance the patient is positive, on third or fourth day the patient will go into more trouble because of the second insult. Particularly for us, newborn is also a concern, and healthcare professionals are highly exposed in gynecology. It is expected that a large number of healthcare workers will turn positive in near future. If patient comes in emergency in labor process or in leaking, where she is untested for corona, we deliver her considered to be positive with full precautions and send for testing. Until then, keep the newborn isolated from mother in a separate room until the report comes. But express breast milk is started immediately because it has been found that it does not get transmitted in breast milk. During delivery, the relatives are now restricted. During labor, there is a big problem because during labor, the patient has little air hunger. And because of that, continuously she will try to remove the mask. So we always tell her that monitoring of oxygen saturation is going on, but don't remove the mask. You can take deep breath, keeping the mouth open, but don't remove the mask. And normally doctor and the staff has to remain at least for 45 minutes to 1 hour in the operation theater or delivery at least, because delivery process will also take suturing and everything will take about 45 minutes to 1 hour. And because of that, there is high risk of exposure. So that is why P99 filter is more advisable. After delivery, we avoid calling any relatives, only one person is allowed. Discharge is as quickly as possible. We vaccinate the newborn immediately, particularly BCG, which is going to be helpful to the newborn. And at home, we advise them to keep mother and child in isolation. And during feeding also, the parents should wear the mask, even at home. Because it has been found that whenever the newborn were found to be infected later on, they were through aerosol only, not direct transmission. So the positive news is that vertical transmission has not been reported to baby till now, as vaginal secretions are also not infective, and micro droplet transmission to baby can occur from mother. So isolation after delivery is recommended and mask to the mother is compulsory. Breast milk per se does not transmit infection, so express breast milk can be given in positive mothers also. Now, little bit I wanted to discuss about the laminar airflow. We have been using laminar airflow in operation theatre since long. Now that creates a positive pressure inside, which is actually not advisable. So since COVID came, we stopped using laminar airflow, but we have to cool the room at least. And there I would like to tell to all the nursing homes that window AC is not recommended. Split AC is okay, but that also ultimately leads to little bit of positive pressure. Until at present ideal changes are done, you should stop using laminar airflow and put an exhaust with fins, which will create a negative pressure in OT. We know that in our toilets also we have an exhaust. If you put a small exhaust will create about 500 CFM negative pressure, and continuous flow of air going out will be very useful. Filter used in HEPA is actually 0.3 micron. Corona is a 0.1 micron size virus, and our N95 cannot also stop it, but because there is a positively charged layer, the N95 mask is actually positively charged, and that is why it is able to stop corona. In HEPA, it is not possible. It is a paper-based filter, and it is not positively charged filter. So it cannot stop the spread of virus. So what is to be done ideally? So ideally, normally laminar airflow throws about 1000 CFM, cubic feet per minute, air inside the room, and it sucks about 900 CFM out of the room. This creates a positive pressure. Air balance is here maintained by exfiltration. It is called exfiltration, where the air is actually going out through the leakages. We need to have negative pressure in the room, where input is 1000 CFM and removal is 1100 CFM. Here the air balance is maintained by infiltration. Now this change which can be done is done at the level of the sucking area, where the air is sucked out. There you can put a small device or a contraption which will actually remove some of the air which is coming filtered out. And so you are trying to increase the outflow of the air little bit. Now that can be done by the HEPA person, and that will create a negative pressure inside. Ideal, if possible, is to have an airlock at the entrance. If you have an airlock at the entrance, there are three types of airlock. One is bubble airlock, one is sink airlock, or cascade airlock. Now cascade is ideal, but in smaller nursing homes, cascade airlock would not be ideal or possible rather. So at least if airlock is not possible, you can at least have a negative pressure in the room by simple changes in the HEPA filter. But if at present there is an emergency, you cannot even call the HEPA person. The best way is to use an exhaust, small exhaust, which has a pin, so that it keeps covered when it is not on. So keep it on, the air will go on into negative pressure. Particularly laparoscopic surgeries are the high risk due to intubation, CO2 insufflation and resultant leakage, and use of electrocautery and harmonic. So as Dr. Ankit Bhai told certain things, I will not go into the same details again, but I have noticed where I go to other operation theaters also, that scavenging facility is not used. There is an outlet at the back of our anesthesia machine. Now that is kept open. So ultimately, whatever gas goes out will go into the air. So we have to use the scavenging thing. It is very easy. You can connect a tube and which goes out of the operation theater. You always use a tight fitting respirator shield like 6800, 3M 6800. And while deflating abdomen, use suction to avoid aerosol formation. In the suction, hypochlorite solution rather than harmonic whenever it has to be used, because harmonic creates larger aerosol, which is more dangerous. Keep the surgical time to shortest. And normally what we do is we don't enter the room unless intubation is over. We keep only one person along with the anesthetist. One in the shortest possible time and go out, and then ETO sterilization is definitely standard. Before that, the instruments have to be soaked in the solution and cleaned. UV chamber we are using now extensively for other things, remaining things, because we don't know that our phones are difficult to sterilize, our key and wallet are difficult to sterilize. This is also a useful thing. And corona is going to stay, so we have trained to manage it.
Thank you very much, Amin Sahib. And Ankit Sahib, there is good news for you. If the surgeon gets annoyed in the ultrasound theater, it is CO2 and nothing else but CO2. So you just relax and enjoy yourself. So coming to the medical side of it, now we have a very senior most cardiologist waiting for us for asking. There are quite a few questions for him. I would ask Dr. Milan Bhai that what do you do in case of emergency PTCA and a planned PTCA when the patient is COVID positive? And in case if there is a with us, then what do you do and how do you go about it?
Yeah, very very important question, Sunil bhai.
No.
See, if patient's status is not known, and if patient comes with acute ST elevation myocardial infarction, then primary treatment is primary angioplasty. So we take all precautions. Actually, luckily in SIMS hospital, we have got facility of PCR by gene expert, where you get report in 45 minutes only. So we send that in emergency. Even say patient has come with head injury and you have to operate immediately, you want to do PCR. RT-PCR takes 8 to 12 hours, but the gene expert gives you in 45 minutes, and it is equally sensitive, 70%. So we do that. So we prepare the patient. The patient has come in here with STLOS and MI. We don't know anything about his COVID status. We take meticulous history, but in today's era now, meticulous history and containment zone and other things are irrelevant. So we think that it is a positive case. We take them like any routine case, but we as a doctor and staff, we take all precautions we may do with level 3 PPE. And of course, I have not done with level 3 PPE also. Even I have just, because we do through radial this thing, we give N95 mask to the patient. You can put additionally face shield also to the patient apart from the staff. So that will protect, and our patients are otherwise, we don't talk too much and we try to prevent aerosol production during this thing. But if patient is really sick, then anesthetic is standby, he is in level 3 PPE, he is ready for intubation. We keep minimum staff in the cath lab, and we do like any routine angioplasty. We do through radial, and there is always lead shield also in between. We also have face shield on our mask, and we have HIV type of kit with N95. So actually we are protected. Now, so that is like any routine patient, and by the time angioplasty is over, which takes about 1 hour, gene expert report is already available. If it is positive, we ship the patient to our COVID hospital, which is a SIMS only, but is a separate building. So, and if it is COVID negative, we keep in our general ICU, but we still wait that we see that he doesn't develop COVID like clinical picture. Then again, scenario is different. Now, suppose patient is COVID positive, proven COVID positive, but is stable in the room. COVID, you know, is a prothrombotic state, inflammatory state. Many times plaque ruptures, and patient had no prior history of angina pectoris, and suddenly he comes with acute STLS and MI. In that case also, if patient is not really very sick, he was not on ventilator or BiPAP or high flow nasal oxygen, and he was not otherwise very sick, you can take this patient for primary PCI to a cath lab in non-COVID hospital also, provided you ultimately clean the cath lab with all the precautions as per advice of your infection disease control committee. And at that time also, you give N95 mask to the patient also, and keep the shield, face shield to the patient, and take all precaution and do PAMI. But we had got so far 3 patients with ST elevation MI when patients were already on ventilator. That's classic ST elevation. In those cases, we have thrombolized. Patients were otherwise also had very severe COVID. They were on ventilator, already intubated because of severe COVID, and then they developed prothrombotic state. They were not a known case of CAD as such, but then we had to intubate. I mean, they were intubated, but we thrombolized them. Actually, none of them actually survived. Out of 3, all 3 died later on.
So you mean to say they died because of thrombolytic therapy, or they did not get the
They died of COVID only.
They died of COVID. So is there anything new normal as far as the coagulation profile is considered, that D dimer then PTA, PTT and all. Is that the same level what we were doing before the pre-COVID era, or now they have changed? Or is there any new normal?
Yeah, there is something very important thing. Many times you are treating COVID, so I know that. But see, many times these patients have prothrombotic state. They develop in situ microthrombi in pulmonary circulation, or in fact in any circulation, even in brain, heart, and they develop acute MI just because of either plaque rupture or in situ thrombosis, where there is no atherosclerotic coronary obstruction. So previously, there is no history also that patient had any kind of risk factor for heart disease, or patient had history of angina, and they develop this prothrombotic state. And many times when your patient is recovering from the COVID, his D dimer remains very high. Is not able to maintain saturation in spite of high flow nasal oxygen or BiPAP, and other markers like CRP, your ferritin, and even IL-6 and other things are normal. And then if you rule out, and the D dimer is 5 times or 10 times more, it is in range of 5,000, 10,000. You are not able to wean him off oxygen or ventilator. That is a not uncommon scenario. Few patients we get like this, where other markers, even CRP is normal, ferritin is normal, your other markers are normal, and D dimer remains very high. So this is possibly because of pulmonary microthrombi, and there we give thrombolytic therapy. We have given in 3 patients, even in Bharatbhai Solanki also, who is a Congress, this person. His D dimer was in 5,000 plus range. So we had given TPA 25 milligram in 1 hour, and then next 25 milligram in 24 hours as infusion, followed by heparin infusion. And actually, even Srujal's father was also given this thing, and I think both actually survived. Otherwise, there so far, I mean, Bharatbhai is still in hospital, is improving gradually, but he had some ATN and dialysis and CRRT and other things, but he is coming out. But Srujal's father could be discharged and he is back home also. So there is another thing to keep in mind: those who are treating COVID in ICU, critical care specialists. If your D dimer is high and other markers are normal, and you have ruled out DIC by normal platelet count, normal PTA, normal FPTT, try TPA. We have discussed this with Cleveland Clinic people also, and they also believe that in this cases TPA should be given. Although there is no clear-cut pulmonary embolism, their RARV are normal, echo is normal, RV strain is normal, but they've got pulmonary microemboli, and they are not able you to come out of a ventilator or oxygen requirement.
So thank you very much, Milan bhai. But then exactly opposite this situation, I would like to ask that we have been chasing this D dimer of the patient of COVID, and we give heparin when the patient is admitted, and the moment the patient is discharged, and still if D dimer is very high, we give them on oral newer anticoagulants.
Yeah.
Now, have you come across any patients who have bleeding diastasis because of that? And hardly we have antidotes for one NOAC, and we don't have antidotes for others. So, have you come across such situation, and what do you do about it?
Yeah, we are giving NOAC in everybody, but we have not got any bleeding issue. But that NOAC dose is actually half. Suppose you are giving rivaroxaban, normal dose is 20 milligram therapeutic dose. We give here 10 milligram per day for 1 month. Or if you are giving apixaban, which is the safest, you give 2.5 milligram twice a day, not 5 milligram twice a day. So dose is half, and usually so far we have given to maybe around 500 patients. No, so far no bleeding. But you are right. If bleeding occurs, there is no antidote available in India for this factor 10A inhibitor. For dabigatran, it is available, but
Yeah.
not for this two.
But
And
that is
then,
very costly, right? 1,25,000 or something like that.
that is very costly. So basically, we give this only apixaban 2.5 BD is the safest dose, and usually bleeding is not an issue.
Okay. And so wouldn't it be safer to use TPA when the patient of acute myocardial infarction comes to you, because it will help you in both the ways if the patient is COVID. So probably in anticipation of DVT or supravenous thrombosis.
It's a very important question in practical also, because there are many situations where there is only one cath lab and patient has there is no setup to have, like SIMS has 3 cath labs. So we can always spare one cath lab for COVID positive patient, and then we can sterilize that entire area later on. But if somebody has one cath lab only in periphery or in even in Ahmedabad city also, in that case you have to thrombolize. If patient has come in golden hour within 1 hour, then thrombolytic therapy is equal to primary PCI angioplasty. So you are not doing anything wrong also. So you're right that a physician should thrombolize the patient without any fear.
Thank you very much. It was very informative. And please don't go away. There are quite a few questions for you. And we
I
will
also
come back.
want to interact in some of the surgical things,
Yeah.
like Sanjeev Bhakti. Can I ask one question?
Yeah, please.
Yeah, see, like when you are doing any routine surgery, not laparoscopic surgery and gas inflation of abdomen, but routine surgery, so if you are doing, say, like hernia appendix, or you are doing on the leg some surgery, when you are using pottery, you are producing fumes, but these are not aerosols which our anesthetists are exposed to. They are not coming out of this. So those fumes, these are, you are burning the tissue, and then those vapors are there, which I don't think they contain any virus. So I mean, you should not get worried. That is what is my belief is. You should not get worried about those fumes which are generated by pottery because you have already burned the tissue. The virus, even if it was there on the tissue, it is already dead, and those fumes are just burning.
Harmless.
So, Milan bhai, can I answer that question?
Yeah, please go ahead.
I think, there is some evidence on this issue. So far, on these aerosols of, the fumes, the COVID virus has not yet been detected. You're right. So, that is a good thing. But the SARS-CoV virus, which was a SARS-MERS virus, that was detected in the fumes. So at least a similar virus has been detected. That is evidence. So at least it is advisable by all of our organizations and their guidelines that we should take all the precautions to control. Initially, it was thought that laparoscopic surgery is more dangerous or unsafe because of these, leakages. But now it is felt that even in open surgery, these fumes are uncontrolled release in the environment. So that may even be more dangerous. So one has to be careful. So what we do is when we are using the cautery, there is somebody holding the suction over there. So all these fumes are evacuated. So basically, these simple precautions need to be taken. We shouldn't neglect this, way of the spread of the virus. So I agree with you that we should not be paranoid about it. That we should not stop using any energy devices, but we should be safe. We should have a kind of a protocol of using, and we should have a safe practice which we should carry.
Quite right. I agree.
And particularly when we are using harmonic, harmonic creates larger sizes, and it is by actually ultrasonic energy. So the probe vibrates at 56,000 RPM, and that cuts the tissues. Now that creates a larger size particle. So still, until the data is not very clear, we would try to avoid harmonic, using harmonic. Bipolar would be a better option, I think. What is your role on Sanjeev on that?
I don't think we avoid harmonic. We use harmonic. I mean, actually, it is felt that because harmonic generates a frequency of more than 50,000 hertz, the aerosolization is higher. But this is not substantiated by evidence. Actually, it does not show that harmonic produces more fumes or harmonic produces more aerosols. So I don't think we avoid using harmonic. But what we do is, we suck out these fumes into a controlled environment. That is what we do.
No, that is okay. It is okay.
Disinfect them. Yeah. We have not stopped using.
But suppose, see the temperature which reaches at the tissues. In case of bipolar, it would be much higher.
Right.
So it is higher chance that it will the virus will be destroyed more quickly. So until now, most of the laparoscopic surgeons have been little advocating that you use bipolar rather than, if possible, then use less use of harmonic. That is going on at present, but there is no data available.
Sorry to interrupt, but then we'll discuss this in a miscellaneous question. There are quite a few questions coming up. Now we go on to the new promising nephrologist, Dr. Hasid Patel. I would like to know his opinion. Is ARBs and ACE inhibitors out of the market because of COVID, or you still recommend them? And what is the situation now? If the patient is already on ACE and ARB, what is your stake? How do you go about it?
Actually, there are two hypotheses which were discussed when ACE-ARBs were there. First is the virus entry through ACE2 receptors and TMP RSS tissue like metalloproteinase that were required for fusion of the virus in the cell membrane and release inside the cell. Now the problem is when we use ACE and ARBs, the hypothesis was that ACE2 receptors are elevated levels are elevated, so virus entry in the cell is increased. But this is a hypothesis that has so far not proven in real world practice. But there is a other school of thought whose hypothesis is if we use ACE or ARBs, then angiotensin to angiotensin 2 conversion is inhibited. So angiotensin is converted into other 1 to 7 angiotensin, and which is vasodilatory and anti-inflammatory. So the other hypothesis is it protects against the inflammation. But in real world practice needs to be evaluated. At present, what is advocated is that if patient is on ACE ARBs, they don't need that thing. If they develop a COVID and if they are stable in the room, then I will suggest that every second day you monitor creatine and potassium. On the first day, if it's more than 0.3 compared to the first day of admission, stop ACRBs to prevent the acute kidney injury. If patient is in ICU, stop ACRBs so that one factor which can cause AKI is negated.
Eliminated.
And later on, after a week or so, or 10 days or so, you can again, after discharge, restart ACE and ARBs. So still ACE and ARBs are not out of market.
So thank you so much. And another question which I want to ask, what are the precautions you would take while getting a dialysis of COVID positive patient done?
First of all, sir, our dialysis patient cannot survive without dialysis. So dialysis unit has to take a precaution. The precaution will be to call the patient before the dialysis session, that whether they are having any fever, cough, sore throat, all the symptoms. If they are having, then don't call in their routine shift, call them in the last shift. If possible, dialyze them in a separate room. If patient is not having this, any of the symptoms, then they can continue this routine dialysis. Always check SpO2 of our dialysis patient, because what is the problem with our dialysis patient is with the fluid overload also they can present with breathless. At that time, it will be very difficult whether he has a COVID or this. He has to unnecessarily go in suspected ward and they're immunosuppressed. So there are chances of contracting there in COVID suspected ward. Another COVID infection is also very high. So this is a care for routine dialysis practice. If patient is already COVID positive, it has to be dialyzed separately in a separate area. The dialyzer tubing has to be use and throw. It cannot be reused even for the same patient. The machine has to be wiped with sterilium. The bed sheet and everything has to be changed. And another thing which has to be taken care is, suppose if patient is in ICU and COVID positive, then his hemodynamics because of this COVID and cytokine storm are altered. So if possible, do an extended hour dialysis like SLED, 6 to 8 hours, so that they tolerate better and all the waste products are removed better.
Thank you. Asit bhai, one more question, that nowadays in most of the indoor patients, about I would say 80 to 90% of the patients, we use remdesivir. And remdesivir, as I said, it can also cause AKI. And so how frequently do you monitor serum creatinine in such patients? And how skeptical about using this remdesivir you are in a known CRF patients?
In known CRF, sir, remdesivir, ideally when it's indicated, it's already a severe disease. So ideally, I would suggest the patient should be monitored when remdesivir is given, daily creatinine and electrolytes, because hyponatremia, hypokalemia, and hyperkalemia, these are the electrolyte abnormality already documented with remdesivir. There are few cases of AKI also, but whether it's because of remdesivir itself or because of COVID, that is difficult to differentiate. So ideally, daily till remdesivir is going on, electrolytes and urea creatinine. The other thing is remdesivir is not indicated. I would not suggest that not indicated, but has not been studied in patients who have a less than 30 GFR. What will be the levels? What will be the pharmacokinetics? What will be the pharmacodynamics? No one knows about that thing. So ideally, we should calculate the bedside tool of eGFR, decide accordingly. If possible, if risk outweighs the benefit, then don't give. But if benefit outweighs the risk, which is always possible in severe COVID cases, then we have to give the remdesivir, and always look for a few symptoms which patient tells you newly, because we are in a phase, I will say phase 3 of remdesivir use. So recently we had a patient that initially she had a mild sensory neural deafness, but after we used remdesivir, her sensory neural deafness increased. Now we cannot confirmly say that it's because of remdesivir, but if few cases happens like this, then we can definitely say that remdesivir can be ototoxic also in kidney patients. So all this has to be taken care of.
So Ashish bhai, how different is AKI in India and AKI in US as far as the COVID is concerned?
Basically, India, the problem with India is we don't have a central registry like US. So exact incidence of acute kidney injury in COVID patients is difficult to say. It will be different in different institute based on their patients' workload and patients how sick they came to their institute. But compared to the Western population, we have a little bit younger population. We have a less comorbid population, and we have a less obese population. So basically, US standards, they tell that 16 to 32%, different literature quotes, that 16 to 32% have AKI. But in India, we are not seeing so much high AKI incidence. And probably that is because we are having a younger population which have preserved GFR, and we are not that much obese as the Western population. And the other genetic factor which is protecting us will be that APOL1 gene. That US population is having that mutation. So that is common in FSGS. So that might be predisposing to COVID related AKI. And Indians don't have that APOL gene mutation very frequently.
So you mean to say they have more virulent disease than...
Definitely.
Thank you very much. Now we go on to the our young pulmonologist, Dr. Nikesh Shah, and there is a whole bunch of questions for him. I'll ask them one by one. Nikesh bhai, how much importance do you give to HRCT positive and COVID negative? Then what will be your stake in such cases?
In many of the cases, we have encountered that COVID test is negative. Patient is showing typical symptoms looking like COVID, and HRCT is also very typical of COVID. Then it should be considered as treated as a COVID positive patient. If they are showing POAD score 4 or 5, okay, and even if the RT-PCR is negative, in several instances we have noticed that even 3 times it is negative. But the HRCT picture is very characteristic of COVID. And there are other aspects of HRCT is also the severity that they are giving by the radiologist. Some are using 25 points, some are using 40 points.
Your voice.
Yes, now I'm audible?
Yeah, now it's okay.
Okay. So sometimes they give 25, sometimes they give 40, and they are giving scoring. And depending on that, we can categorize in a mild, moderate, or severe category on HRCT appearance. So we have to consider HRCT equally important in diagnosis case of COVID.
Yeah. So there is another tricky question for you, sir. What type of PPE you would use in a different scenario? Supposing in OT, while taking a round, while taking a non-COVID round, while dressing the patient, while just doing a echo or sonography, do you suggest the same kind of PPE, or there can be a difference in PPE, use of PPE?
We usually there is some change in the PPE protocol because the PPE which is being wear in a COVID hospital or COVID admitted patient areas is different, because that PPE can't wear in a OPD. It is extremely difficult to wear this wear in a OPD for 3, 4, 5 hours sitting in a chair, and tolerating that PPE is extremely difficult. So what practicality we are using, or which in SIMS hospital we are doing, we are using a simple surgical gown which made of cotton along with a N95 mask, which is also covered by a triple layer mask or 3-ply mask. So they are double protection. One is N95, another is a 3-ply mask. In addition, we are using the shield, that is a face shield. So if any aerosol generating procedure or patient is coughing on your face, then you are being protected from that thing. We are using gloves, and occasionally in certain areas when we are entering, we also use the foot this protector also, like that. But usually it is a
Okay,
surgical
please.
gown. If we want to protect us more, like suppose we are entering an area which has got more aerosol generation, even in a non-COVID area, because you never know which patient is COVID, even in a non-COVID areas. So sometime in addition to this surgical gown, which is made of cotton, we are adding a plastic apron, which is a disposable, which is hardly costing anything and which can be immediately thrown away, like that, with a simple plastic apron. So it can be, you can change several plastic aprons in a day. So that is also economize the things also. So this is a simple PP protocol.
Is XHS is enough for you, or you want HRCT in every patient?
If COVID is positive and patient is exhibiting mild symptoms, then usually
Hello?
HRCT is not recommended in such scenario. But if the patient is showing typical symptoms of COVID, RT-PCR or even rapid test is negative, you are confused what you have to answer to the patient, then we go for HRCT evaluation.
Barabar. And can you say, just in few words, can you tell us steroid and non-steroid? When to use, when not to use?
Usually steroid is not to be used in a first week of COVID illness or in a milder cases. Okay, usually it is being reserved in a second week of illness when the patient is still symptomatic at the end of first week. You have given antiviral like HCQ, doxycycline, ivermectin, or whatever you have given to the patient, and patient still remains symptomatic at the end of 1 week, and he is showing high grade fever or is showing hypoxia, then we use steroid. It should not be used at just beginning of COVID illness.
Right. And the last question, when do you use BAL RT-PCR compared to the nasal swab?
BAL we hardly do in a COVID patient.
So
Is
there is there any indication? No.
No, not at all. Because it is hazardous procedure to the performing as well as to the staff. So it is not recommended.
It is not recommended. So,
Yes.
sir, our observation is we have by now we have admitted 500 patients in HCG hospitals, and our experience, we being a primary warrior, we have seen that there are very few patients who have bronchial asthma, tuberculosis, pulmonary fibrosis who are having a COVID infection. Compared to that, those who are smoker, those who are young, those who are old age, they have more COVID infection. So do you think they have some obscure immunity or something like that?
It is likely because at the outset of corona outbreak, I was also assuming that I will getting lots of asthma exacerbation, but unfortunately I have not received any asthma exacerbation because of the COVID, and I have not seen any of tuberculosis patient. I have got lots of tuberculosis patient, but nobody has turned up as a corona positive.
Right.
So this is a surprising fact. So some hidden T cell mediated immunity is playing a major role in making them COVID positive. And even they become COVID positive, they are not so severe as we expect them to be.
Yeah,
So,
and another thing we observe is that those who had swine flu, they are also not turning up as a COVID. So there has to be some connection.
yes,
Do you
yes, it is like COVID just a jungle ka raja ho gaya. Means no,
think-
nothing is seen. No illness is seen.
no,
You are
no,
not.
no, those who had swine flu in the past, they are not coming as a
They are
COVID
not also
patient.
coming. Yes, yes. Even the fresh swine flu cases are also not coming into
Okay.
the picture.
Thank you so much. Now we go on to Dr. Sanjay Rajput. He's been waiting since long. He had a nice tea and snacks also. We could see them having it on the video also. Now, Sanjay bhai, endoscopy or no endoscopy in COVID patient?
In initial phase, sir, we have stopped doing routine endoscopy because of lot of fear of aerosolization, and we have started teleconsultation. We were
Hello.
avoiding the patients to come to our clinic, and then gradually, when these cases are decreasing, we are now going towards the normal way of endoscopy and routine consulting after screening them on teleconsultation, whether they are serious or not, whether they need in-house consulting or not. But endoscopy per se, we cannot wait in hematemesis. Like just now, I have got one patient of foreign body which is sick there. So as soon as this is going to over, I have to remove the foreign body. So emergencies can't wait in endoscopy. So we have to do emergency ERCP in cholangitis, hematemesis, foreign bodies, PEG for feeding. So all these procedures were going on with all the precautions as all people are saying, like N95 mask with triple layer mask over it, and then seal in OPD, and with this mask with respirator in our all endoscopy procedure we wear this mask, and our with full PPE kit. So we are taking precautions for us as well as for the patients also.
And sir, after removing the endoscope, what care should be taken?
Actually, we were taking all the care before even lockdown also, because I thought on 12th of March we have started using to all our staff and ourselves. And in the beginning only, I realized that this is there is something aerosol in this pandemic, because otherwise it cannot spread so fast to the people. Like in Italy, it was rampant. In New York, it was rampant. So we were taking all precaution of wearing masks in 12th March. I bought around 595 masks on 12th of March and giving it to all our staff. So basically there is something called sixth sense which we can sense, and all the patients we are taking all the precautions for not to increase their risk of corona also. So the problem is that what Dr. Amin has said, that we have 6 people in our group, and the group practice has always helped as in all situations. So we have divided our practice. One day only one person was coming, so we are getting less and less exposed. In all the five months, we have divided our duties. Even in our staff, we have divided our duties. Like we were giving only 2 or 3 staff because only 2 or 3 or 4 procedures were coming. So we needed less staff. So we have divided that also. And we were not calling the patient who are very sick.
Sir, my question was slightly different. What care do you take after removing the endoscope?
It doesn't make any difference whether you do in COVID patient or non-COVID patient. You have to take all precaution. Even during non-COVID area, you have to sterilize the whole scope as if it is COVID patient, because you are taking precaution for HIV, HBsAg, and HCV. It is no different than for the COVID patient.
So another question for you is that we've been using remdesivir very frequently in all the patients who are indoor. And
yeah, we have to be very careful.
Yes. So
hepatitis.
It alters the LFT.
Yes, yes.
Initially, COVID itself, the COVID infection itself causes SGPT high, SGOT high. So how do you differentiate between the two?
I think if COVID is there, we have to, like in AKT. AKT ની અંદર કેવું છે કે તમે જ્યારે કોક્સ liver ની અંદર જ હોય. COVID is in the liver. You don't have to worry much about the side effect, because we have to do the give it as a life-saving drug. So we have to monitor prothrombin time. Whether if prothrombin time is deteriorating, like in all COVID patients, prothrombin time remains as much normal as rather than other things, because the synthetic function of liver does not deteriorate. So you have to be very careful in monitoring them. And most of the time we have seen that patient comes out of this phase also, or even on remdesivir.
So according to you, which is the safe limit of SGPT, SGOT?
I think SGPT, SGOT ni karta bhi sahib, tamare prothrombin time is the marker you have to monitor.
Fine, fine.
SGOT and SGPT.
And many patients we have seen after the treatment of COVID infection, the patient has completely recovered. All parameters have come back to normal, but LFT doesn't come back to normal.
Yeah, it takes longer time, because most of the time, like in hepatitis B, it remains in the liver.
Right.
So in liver cell, the COVID remains, and it will gradually comes out of that. That is why this sometimes what happens, the patient, જેમ કે myocarditis છે, patient ઘરે ગયા પછી પણ મરી જાય છે.
Right.
You have seen that patient went home, he ate a good diet and then he died because of the myocarditis. That is like in liver also, you have to take care later on also.
Thank you so much. You can take care of that foreign body. We go to some other speaker.
Thank you so much.
Dr. Ashish Kaushal has been waiting since quite some time. We have an onco-physician with us. And let us ask him a question that what do you expect when a patient comes to you for a chemotherapy? Would you ask for a COVID test, or you would go ahead with the treatment, or you don't require it?
So first of all, we need to understand regarding the risk of that particular patient. So, the cancer patient is vulnerable for getting COVID infection. And if the cancer patient is at screening, if the patient is COVID symptom free, that we normally do as a institutional protocol. And then if the patient is eligible for any chemotherapy, then we need to decide whether this patient is taking the treatment as a daycare unit or the patient is taking the treatment as an indoor unit. So daycare treatment is relatively easy, where we have because the SCG has a separate daycare building, which is not connected with the indoor unit. So the patients are coming directly to the separate building where the patient has been gone for the screening at the baseline. And after that, patient go to the daycare unit, and we do a daycare chemotherapy without doing testing. And as of now, in last 3-4 months, we have done more than 3,000 chemotherapy without any single patient who died after receiving chemotherapy. So we are fortunate that enough. But those patients who are receiving indoor chemotherapy, we have institutional protocol as of now, doing the baseline RT-PCR for the patient. And those patients who are staying for overnight, whether it's the PCR is the patient in a separate room, and after getting the PCR report in 6 to 8 hours, we admit the patient and we start the treatment, provided the patient should be COVID symptom free. And suppose if the patient is receiving chemotherapy for more than 1 day, I think the only thing which we are taking another precaution, we are allowing only one relative to stay during the entire course of the treatment. If the suppose this patient receiving for 3 or 4 days chemotherapy, the only one relative which are there at the beginning, the same patient is going to stay with the patient unless and until there is an emergency. So that's another important thing. And besides that, we are taking all the routine precautions, including PPE and appointment system, those kind of things, very important, because if the 10 patients are coming in the same time, that would be more difficult for the staff to manage. So that's why we are strictly following the appointment system, especially in daycare units.
So Ashish bhai, do you need to modify your dose of oral chemo or injectable chemo because of COVID?
Yeah, definitely. Basically, it depends on the patient treatment. So all patients treatment is not modified. In general, I would say majority of the patients are in our center are receiving the standard treatment. The modification is done where the patient is high risk for the post-chemotherapy complications, especially neutropenia. So the things what we are doing in our practice, the more aggressive regimens are usually we avoid if the benefit of that regimen is marginal. That's the one thing. The second thing, if the patient is eligible for any oral treatment, for example, in an advanced head and neck cancer patient, where we can offer a oral metronomic chemotherapy rather than injectable chemotherapy. So those kind of the patient we can modify if there is only marginal benefit of the injectable chemotherapy. And the regimen which is causing a myelosuppressive, the patient is a curative potential, and we need to give that chemotherapy. I think we are using the growth factor as a routine prophylaxis, especially if the patient are the risk for an neutropenia. So these are the modifications we are doing in our practice, but still majority of the patient we are doing a standard treatment without any complication.
Do you think the recovery is delayed a bit because of COVID infection, or they have more side effects of the drug because of COVID, or is there any observation like that you have come across?
So there are a lot of incidents where the patient are receiving the chemotherapy and they found a COVID infection before the subsequent chemotherapy. So the patient who received aggressive chemotherapy, when they came for the second chemotherapy, we do it because we are doing the test before every cycle, even every 21 days. So those patients receiving chemotherapy after even the 7 days, we are doing the testing, and the patient who turns positive, even they are asymptomatic. So as of now, we have not come across any patient who died post receiving the chemotherapy, but still the patient who are scheduled for the chemotherapy, we are doing precaution, and most of the patients are taken care of. The only concern, there are the certain patients whose advanced malignancy, they are the supportive, they admit, and on testing, they found a COVID infection, but I think the chemotherapy doesn't increase the risk of the COVID infection. The only thing we need to take care of the proper precautions.
Do you wear complete PPE while treating them?
So not level 3 PPE. So what we do in our practice, we do a N95 mask, face shield, disposable gown, gloves, and hand sanitizer when we change the patient. Every patient when we are seeing, and after that we pre and post we are doing this thing. So these are and all the staff are taking the same precautions.
Thank you very much. Now we go on to the last bestman, that is Dr. Kapil Shah. He is an ophthalmologist, and everybody must be wondering what ophthalmologist is doing here. So there are quite a few things which can happen in ophthalmology. So let us hear from him. Dr. Kapil.
Yes, sir. Kalpit, sir.
Can you give me something regarding COVID and eye?
So regarding the symptoms wise or the disease wise, if we say, the first thing like the conjunctivitis, that viral conjunctivitis. And if you happen to know that the first patient of COVID was diagnosed by an ophthalmologist in China, and the Chinese authority, then there is a mystery that whether he was died because of the COVID infection or the authority has killed him, and that is not sure. But the first COVID patient was diagnosed by an ophthalmologist by looking at that viral conjunctivitis. So the viral conjunctivitis is not that much common, but still that we can see the virus from the tear as well as from the aqueous. So virus conjunctivitis and the eye can also be a route of entry for the virus. Second thing is like Dr. Milan sir was telling that regarding that like hyper coagulative factor, same thing happens with the retina, that venous occlusion, retinal arterial occlusion and the retinal venous occlusion. The patients are more nowadays are coming with the venous occlusion after the COVID infection. So there are a few like 4 or 5 patients even I have seen, like they come after recovering the COVID, but they had a problem with that venous occlusion and the visual problem. The third, I would say, like because of the steroid use, there should be a continuous monitoring, because the steroid can definitely cause the cataract as well as the glaucoma. And there are quite a few that post-COVID infection who have survived and who has recovered, but that cataract might have progressed or they have developed a new cataract because of the steroid. So these are the some of the points that because of the COVID, that visual problem can be seen or they can occur because of the COVID infection. Sir.
What eye care would you suggest in a patient who is COVID or who is non-COVID or the health professional like us?
Fine. So regarding the care, eye care, like not touch the eye when there is a like aqueous secretion or when there is a tear secretion, there is a watering. Like use always the disposable type of wipes. So whenever there is a tearing or there is a something, like wipes with the disposable wipes and throw it away. Second, don't ignore the redness of the eye. Either it could be a simple allergic or it could be a viral infection. So that we have to take care. Or so like for the normal person, I would say that they have to consult the ophthalmologist for that particular problem. Regarding then as an ophthalmologist, like how we should take care while examining the patient, the normal as everybody has told, like the normal scenario PP kit, like the normal gown, the face shield, N95 and the 3-ply mask. But for the specific ophthalmic use, like when we have to come very close to the patient, so we have to use like a face shield. With the face shield, we can't do proper slit lamp examination. So we can put some face shield like a curtain over the slit lamp. We have made like that. So every slit lamp would be with the shield. So when we examine the patient, direct aerosol not coming to us. Same with for the retinal checkup, like or different instruments, we put one a plastic cover. So for that plastic cover, the direct contact with the patient or direct aerosol cannot come to the ophthalmologist. These are regarding the like examination purpose. Second, like as I told, like when we do the surgery in any eye, like in any ocular surgery, because the ocular surface contain the virus. So as like everybody knows, the betadine is a very good antiviral property, especially for the ocular surface, even in some viral conjunctivitis, not COVID, but adenoviral or simple other viral conjunctivitis. Betadine drops nowadays as a promising role that they can kill the virus. So before any ocular surgery, betadine wash is mandatory. So whatever the infection, the viral infection or viral load is present over the ocular surface, that can be washed away. as Dr. Milan sir was telling that cautery can be harmful or not, but for the ophthalmic purpose, like for a squint surgery, we have to use the cautery, that bipolar cautery. And as there is a presence of viral infection or viral load over the ocular surface, when we do the cautery of the conjunctiva or any muscle, then there could be chances of aerosol generation. So in that case, we have to use the cautery, but in that case, instead of putting a normal saline, we can put the betadine drops. So that that can reduce the viral load, whatever is aerosol is generating. Second, like in aqueous also, like intraocular fluid also, they have come across that some viral load is there. So when we do the intraocular surgery, say for example, the phaco, in phaco emulsification, there is an aerosol generating procedure because there is piezoelectric crystals are there. And because of the piezoelectric crystal, there is a direct to and fro movement of that probe that can create the aerosol. So before starting the phaco surgery, whatever the aqueous is present in the anterior chamber in the eye, we wash away with the normal saline. So there are less chances that we can generate the aerosol from the aqueous. So these are some of the points related to the ocular surgeries. Yes.
Sorry. No, please go ahead.
Yes, sir. Yes, sir. Regarding sir, that another thing, like Dr. Ankit Bhai is there as an anesthetist, like my main work related to the pediatric ophthalmology. So during the general anesthesia, as he has told, like, is there any role like is a normal ocular surgery? We did a trial like putting in a local surgery, like we put one mask over the nose, and in that mask one hole is for that oxygen inhalation, and exhalation mask, that tube we connect, and that tube we keep in that sodium hypochlorite solution, the suction bottle. So is it advisable or not?
Yes, you can use anything which is coming out and goes directly to the hypochlorite solution. You can use that. Yeah, that's a good idea in the way, but it should be a closed system basically behind the mask.
Yeah, suction
The
machine,
exhalation.
and
Yeah.
yeah, specifically whenever like we operate the patient, because we have to operate near that structure, so we always ask the patient to wear the N95 mask along with the 3-ply mask, and the oxygen generally, if required, we continuously give to that patient, and we keep the sticking plaster over that mask. So from any side surrounding that mask, no aerosol or no from exhalation, anything is coming from that. So as Ankit Bhai was telling,
generally
yes,
we don't use anything if the patient is having mask without valveless mask. Nothing is needed to suck out the air behind the mask, from behind the mask. So you have to use a tight fitting mask. That's it. In in a procedure where it is done in regional.
yes. So sticking plaster we can apply, because sometimes the 3-ply mask is not fitting properly. So if we can apply the sticking plaster all around the mask, so that will prevent the exhaled air coming from that mask.
That should be the right way.
So,
The mask fitting, or you can use an N95 mask over the patient also, which is a tight fitting mask, N95 with the patient.
So Kalpit Bhai.
Yes, sir.
Apart from betadine eye drops, do you use steroid eye drops if required?
For viral conjunctivitis, there is a role of steroid. Like initial case, when there is a mild load, we don't give steroid. But if the symptoms are like that because of the conjunctivitis, if it is creating some problem over the cornea, that inflammatory reaction, then of course there is a role of steroid.
Okay. And does COVID cause any refractory error?
No, no.
Have you
There is
seen
no change of
No,
no change. No.
So thank you very much. Now all the speakers are over. So we have now miscellaneous questions here with us, and anybody can answer. You can raise the hand and answer if you feel you can answer it properly. Yes. So the first question is the vaccine? Yes, Kalpit, you want to say something?
No, sir. Just I wanted to ask. That's why I raised my hand. But we can do that question afterward.
Okay. So the first question is, do you all feel, the panelists, the vaccine would be the final answer for COVID? And what is the future of this vaccine? Anybody? Yeah, Milan bhai.
Can I, okay, Dr. Amin wants to tell, but okay,
No.
I'll just tell in 1 minute. See, vaccine, it is a flu virus, and we know that even common flu, we take shot every year. So
Yeah.
whatever immunity we get is a short lasting. And these vaccines of various proteins, I mean, vaccine is produced against various proteins of this virus, which is cell membrane and spike protein and other things. We don't know how long that vaccine will be effective. That is one thing. Even it is said that patient who gets COVID, if COVID is very mild, his immunity may last for 3-4 months only. So don't feel that you had COVID, so you are protected for next
Yes.
1 year. So that is true clinically also. In our day-to-day practice, we always tell our patient. So, and secondly, the disease where 85 to 90% patients recover spontaneously even without any treatment. We don't know whether somebody has given me shot of vaccine and I am little bit okay, whether I get infection and I get all right. We don't know what will be the real efficacy of vaccine, or it was a spontaneous recovery even if I get COVID. So it may make the COVID mild, whether it will protect you 100% and how long, nobody knows. And it will be ultimately like that only, that like we are taking flu shot every year, we will be taking COVID shot also every 6 months or 1 year. Let us see.
Supposing they come out with vaccine on 15th of August, as they're expecting to announce it. So would you take it?
Me, no.
Then what is preventing you to take that?
Yeah, I would like to see whether it's really efficacious. There is no side effect. I mean, even people who are doing a lot of research on vaccine, they also say that it will take at least till December, January. You cannot expect any vaccine which is of proven safety.
Right.
Efficacy is one part, but safety has to be there. So you cannot just find out vaccine in 3-4 months. Normally it takes, so far also we don't have vaccine for HIV today. So
right.
we don't have
Nice,
vaccine.
Milan bhai. You cannot rely on the testing. It has been very less tested vaccine, so we would not go for it quickly.
Yeah.
I think that is right. And as we have seen that all these vaccines would still have, even in spite of taking vaccine, the disease does occur. And so this is not going to be Rambani Ilaj. That is for sure. But it is a light at the end of tunnel. So if people are shown light, so that they will start working basically.
Yeah, it is
Supposing one patient comes to you and tells you that I have suffered from COVID, my antibody test is positive. Still, do I need vaccine?
Nobody knows.
I think the
Nobody
best
knows.
answer is
The
to check.
purpose of a vaccine is to create antibodies.
Yeah.
Why would you need a vaccine if you have antibodies?
Yeah, if the antibodies is there, we can avoid that.
There is
But
a
what is
level
the-
of antibody.
Didi,
There
what
is a
is the-
level of antibody.
Sir, level of
please.
antibody. What is the level you would expect?
Yeah, it is. It should be more than 15, I guess, which is protective. Less than 15 is not protective. That is what they say.
Okay. So this is an arbitrary figure, or it has been documented anywhere?
So far, I have not come across the literature, but the friends in US and all that, they say that more than 15, even if you go to a laboratory specialist, they also say more than 15 is enough to cover or protect. Less than 15 is not protective to you.
So supposing if your patient wants to donate blood after COVID infection, he is antibody positive.
Minimum.
What
Minimum
level you would expect? What level you will give?
Minimum 15 is required. That is what
Less than 15 you don't give?
No. No.
What is 15? What is unit? What are the units of this antibody? What is 15?
No idea about
units. We don't know, but that's what they mentioned.
Yeah. So you have to have minimum antibody level to donate plasma. But you can just not go and donate the plasma.
It must be IU, international unit or something. Some unit must be there.
Now,
but one thing is there that viral load will also remain important. Even though a person is immune, if the viral load is more, then definitely they will get COVID.
I agree.
So doctors are at high risk at every time.
See, that is true for every vaccine. If the
Right.
load is more, they are not protecting yourself. But then the general protection is there. So
Right.
another question is a brainstorming question. Everybody, I would like everybody to answer this question in their way. Why mortality is more in doctors?
Okay.
Yeah.
So I think doctors are exposed to the high viral load because of aerosolization. That is one. The level of exposure, the more than 15 minutes, it is said that it is a high level exposure. If you are exposed to less than 10 or 15 minutes, because we are seeing that amongst the family members, the transmission is very common. In the general population, it's not that common. Among the family members, it's very, very common. So that also shows that, with a prolonged exposure, the transmission of these viruses is very high. And doctors have a higher viral load. I mean, they are exposed to high viral load because the level of exposure would be higher. So I think that is one of the reasons why the mortality would be high.
Anybody? Yeah, please.
Yeah.
Arvind sir.
Yeah, the second point might be that there may be different strains of virus which may be working, and most of the milder strains, the patient would remain at home, so they would not come in contact with the doctors. The serious patient who are coming in contact with the doctors must be having a serious strain, right? Until now, I think 18 to 20 different strains have been identified. Out of them, significantly 3 are significantly different.
Yes.
So that may be one of the
High
reasons.
viral load patients are more in the ICU and in the hospital.
Milan bhai?
Yeah, I think even though we are all doctors, don't believe that we have good immunity power. Most of the doctors have very poor immunity powers.
I know, I can understand.
Overworking and
Yes.
irregular lifestyle. Yeah.
That's right.
So Milan bhai, any comments from your side?
Personally, I have communicated to so many doctors. Many of these doctors, being a doctor, they think that it is a like minor cough or malaise or something. So initially for 3-4 days, they just take self-medication like simple paracetamol only, and they still were running the OPD. Even my known friends and colleagues were doing that thing. So
Yes.
that 3, 4, 5 days of delay, and they were rather than taking rest. Viral illness means you have to take rest, adequate hydration. These things were actually missed by doctors themselves, and they were running OPD heavily. Lockdown was suddenly opened up, so waiting list was very high. It was a mistake from the part of doctors themselves that they neglected their illness for initial 3 to 5 days, did not take enough rest. They continued with paracetamol, and that actually made the disease more virulent in them.
So you mean to say the doctors are worse patients?
Doctors are worse patient. They realize now. Now people are taking precautions after so many days.
Yes.
Early infection, and in early era we are not knowing this.
Can I ask you?
Yes.
Can I ask you, Sunil bhai?
Yes.
If somebody gets, say, a doctor gets a fever, on the should he take RT-PCR COVID? Should he wait?
No, first day he may not get. You should wait for 2 to 3 days to do that. But then from first day onward, he has to take all the precautions. He has to isolate himself. He has to do a corroborative test, like you can get CRP, CBC, all these tests can be done. And second or third day, you can get a COVID test done. That would be really effective. And HRCT should be done after 4th or 5th day, not before that, because it's going to give you a wrong information. So any doctor who has the malaise, I would say don't fever, even malaise also, he should take rest at home, start treating himself with antibiotics and this thing, whatever is that. And the moment the evidence of COVID comes, he has to bombard himself with antivirals. That is the way out, I think. And he has to curtain himself. He should not go out, and he has to behave like other patients also.
Yes, Sunil bhai, can I ask a question?
Yes.
Yeah, what is your take on use of metformin? Those who are already on metformin, or there have been a lot of papers which are telling it is useful to prevent.
Yeah, it is supposed to be a useful drug, but then if there are certain caveats, if the patient has altered liver function, if the patient has altered renal functions, then metformin is of no use and it should be withdrawn.
Correct.
Otherwise, if the patient is having a good appetite and no other comorbid condition like this, then you can go ahead with metformin. But not that you should add metformin to treat COVID. Those who are already on metformin, you can continue with it, but then you should not add it for the treatment point of view. See, that way, I think Milan Bhai will throw more light, but all anti-triglyceride drugs are also very effective because the virus takes lipid route to travel inside the lungs. And if you fail your lipids well, and lipid drugs are also quite effective that way. So, Milan Bhai, your take on this?
Yeah, you are absolutely right. Statins are now part of prescription in many of the institutes in Western countries. And I also personally believe that statin has, I mean, anti-inflammatory action. We know that. Hmm? So all those actions are helpful in COVID also. Although there is no randomized trial, but we should give it. If
But
your liver is okay, SCPT is okay, we should give it.
but
And I just want to discuss one thing more.
yes,
If I am symptomatic, see, suppose my family member, my wife or my daughter had COVID positive, and I am exposed because we are not having social distancing at home. Then if I get symptom, then why should I wait for a few days? I should get RT-PCR test done on day one only. Why should
no,
if
I don't
symptom,
deny that. I don't deny that because you are exposed, and yes, you can
as
do
a
that.
doctor,
You
you
can,
are in clinic, you are a
yeah.
symptomatic now. So as a doctor, if you are a symptomatic on day one, why should wait to have more symptoms?
Chance of getting negative report must be higher, I
Yes,
think, on day one.
you should take all precautions. You behave that as if you have got COVID, and you may repeat the test after 2 days or whenever you wish. But first
I,
test, we should not wait for first test also. Why should we wait? I mean, there is no advantage. I have
Milan
seen
bhai,
so
I
many
agree.
patients.
Milan bhai, I 100% agree with you, but there is a caveat that the day one, if the patient gets infection, the viremia is less. The second and third days, the viremia increases. So that
It's
if you
true.
do it that time, the chances of getting positives are much higher than compared to doing on the first day. So there can be a false negative result, and you are under an impression that you don't have this.
No, no, that under impression or false sense of security should not be there. But there is no harm in doing on day
So
one.
there is no harm. There is no harm in doing it.
Actually,
If you are, yeah, if you
actually,
are going to repeat it, then there
we
is no
had
harm.
a
there is no
no,
harm.
we had a discussion on this.
You're
Our two
talking about for the
anesthesiologists.
contact, or this is for those patient who has been having symptomatic. So somebody is in contact, I think we should wait for at least for 72 hours. But somebody symptomatic, I think I would agree with Dr. Milan. He should at least test for on the day one. I think why should wait for that?
Actually, the if you see the spread, 24 hours before the first symptom and 48 hours after the symptom is the highest time for spread. So that means that the viremia is the highest.
Right.
So RT-PCR would come positive on the first day itself, if it is going to come positive. So most of the people believe our critical care specialist. We had two anesthesiologists recently had fever. So on the first day they were advised RT-PCR test. Both had negative test. But then this discussion, they said that, first day generally it would come positive if it is going to be positive. So, I mean, I don't know what is the current, recommendation.
See, the general take is symptomatic, yes, do it. If not symptomatic, you wait for 1 or 2 days and then get it done. And
Maybe on the fourth day you can repeat if the fever continues.
yes, there is no harm in waiting, doing again second
Yeah.
time. There is
Yeah.
no harm. Now, if anybody wants to comment, yes. Otherwise, another question I should ask.
I just want to ask nephrologist if it is there.
Yes,
Yes.
he's here.
If okay, fine. So if say patient is a known case of end-stage renal disease, he is already on maintenance dialysis, and now he becomes COVID positive. So can we give remdesivir to him? The recommendation or drug precise that okay, if EGFR is less than 30, you don't give it. So all this end-stage renal disease will have EGFR of less than 15, right? So
Yes.
should we give remdesivir in a patient who is already on maintenance hemodialysis?
Definitely, sir, because in severe patients, the benefit definitely outweighs the risk. The problem is our CKD patients are kept out of clinical trials every time because there are chances that drug might get rejected if they get bad results. No one has studied the plasma level of remdesivir, how it behaves in CKD patients. Like in hepatitis B, sofosbuvir when came, they also told that less than 30 GFR, it cannot be given. But then someone did a trial of pharmacokinetics and pharmacodynamics and showed that in less than 30 GFR, the sofosbuvir levels are double than the normal plasma levels. So what intermediate way we did is, if separate tablet is available, give half sofosbuvir or give on alternate day. And many of our CKD patients have been cured of hepatitis C by this thing. So remdesivir plasma level, what is going to happen, we cannot predict. But for that part of, we cannot deny the benefit of that treatment to the patient of CKD. Because if it's deteriorating and is going in severe, then nothing can be saved except remdesivir. Tocilizumab in CKD patients, because they are having frequent hospital visits and all these things, they will be having nosocomial infections. They will be harboring like anything. So if by chance they get secondary bacterial infection after tocilizumab, then I think meropenem or colistin only we have in our armamentarium for CKD patient. But I will advise that for 5 days, initially we give daily if patient is sick. And if they tell in very sick patient, you can continue up to 10 days. But after 5 days in CKD patients, at least we should stop, because we don't have the further safety data profile. And the only problem with this one is the vehicle is cyclodextrin of remdesivir. The same with voriconazole. We can't use in CKD because cyclodextrin is there. Cyclodextrin gets accumulated and causes liver toxicity. But on dialysis patient, that cyclodextrin can be dialyzed. So who are not on dialysis, we have to be watchful for giving remdesivir. But who are on dialysis, the cyclodextrin can be removed. And remdesivir itself doesn't have any other proven side effect except liver toxicity. It can cause mild mitochondrial toxicity. But so far we have given in 3 patients, sir. And fortunately, no other side effects have been found. And we monitor daily LFTs.
Asit bhai, then one more question for regarding this only. Supposing if I give remdesivir to the patient of CRF and you want to do a dialysis, how much time period you would allow it to go so that it doesn't get dialyzed?
Generally, sir, it's very well protein bound and all these things. So not enough time, but generally all the medicines which are in trial phase, we generally prefer that after dialysis you give.
Okay.
So that it's not dialyzed. And CRRT and all these things, if going on, then we don't know how much portion is removed. Even if the drugs is used since 10 years or 15 years, in that also we don't have that much frequent studies. So basically we prefer that give after dialysis, if on alternate day dialysis. If CRRT, give regular dose at regular time. The only problem with remdesivir is cyclodextrin, that vehicle, which is can cause liver necrosis when given less than 30 GFR, because it cannot be eliminated by kidneys. And other thing is that remdesivir is a prodrug. And after activation, whether that metabolite is excreted by kidney or not, that is not studied frequently. But over a time, I think by 3 to 6 months, someone by government sponsor or by pharma sponsor will study the plasma level of remdesivir in CKD patients, and then accordingly we can do dose adjustments.
The same thing for tocilizumab?
Tocilizumab doesn't require dose adjustment in CKD. It can be given out of that.
But that is also dialyzable?
That is, we prefer after dialysis only.
Okay. So if anybody wants to comment, there is another question coming, but then if anybody wants to comment on this, go ahead.
One thing I would like to say, sir, about that doctor's mortality and all these things. This carelessness, our stress levels, irregular dietary habits, irregular sleep habits. In addition, we are mostly working in hospitals. And if we study our nosocomial infections, if we study our nasal swab or if we take our rectal swab, then mostly we will be harboring multi-drug resistant bacteria. So that might also be the cause for higher mortality, because if after viral infection, if we develop bacteremia due to any cause, then probably multi-drug, we are having that with multi-drug resistant organisms only.
Now, everybody is talking of raise your immunity, raise your immunity. How do I do that? Tell me, can anybody tell me how do I do that? what is the parameter? What is the treatment? How do I do that? Is that the drug? Is that the exercise? Is that the lifestyle? What is it? How do I increase my immunity? And what is the parameter to know my immunity?
Lifestyle, Sunil bhai, whatever you are doing and giving advice to your patients daily, that is the only thing. I don't think it is said that, okay, if your vitamin D is less, then it is slightly disadvantageous. So you replace your vitamin D. But normal vitamin D and you take vitamin D, that is not helpful. Zinc and vitamin C and other things, nobody knows. I mean, nobody has done randomized trial. So, but there is no harm and they are cheap, so people are taking.
I know, but this thing, I 100% agree with you. But what I feel is the exercise is a very good immunobusters.
Yeah, that is true.
But because of this lockdown and all that, the people have thought that the exercise should not be done. And that could be the reason why they have stopped doing an exercise and they are putting on weight. They are couch potato and all that. And so we must insist on all our patients that yes, exercise whatever way they can do it, they should continue with it. And don't remain hungry for a long time. Have proper balanced diet. That's the only way to increase your immunity. I think any other suggestion, then I'm ready to accept it. But then this is what I feel about it.
You are absolutely right. Healthy lifestyle is the best thing. Enough sleep, 7 hours sleep, good diet, and mental peace, yoga, meditation, and exercise. Everything helps.
Okay. Now, the last most controversial question is, do you believe in HCQS prophylaxis?
I personally believe in SIMS, we have given to all our 1200 employees. I mean, we have taken ECG as a baseline and after 2 doses, but we are giving and we are continuing. Somebody had asked how long till pandemic last we should continue. I mean, it's not 7 weeks, which was given initially in ICMR guideline, and they never modified it. So many people stop after 7 weeks. So that was a wrong thing. Till burden is there in the society, I think we should continue. We all are highly, I mean, vulnerable people as far as healthcare workers are concerned. So we should take HCQ prophylaxis. I have seen so many patients who somebody was not tolerating HCQ because of say reaction, diarrhea, vomiting, and abdominal pain. I have seen several families where one person was not able to take HCQ, and he or she got COVID, and others were protected in same family, in same household. So I personally, and even whatever basic data by All India Institute of Medical Science people is there, ICMR also say. I don't know why ICMR is not doing scientific study and have analysis and publication. That is the worst part from ICMR side. ICMR is a lousy body, in my opinion. So far, so-called Premier Institute of Research of India has not published any data so far. Although they believe that HCQ is working. I personally, I started taking in May actually, not initially, but in mid-May when Ahmedabad was peaking very high. Sims was if there was no bed in Sims, if I got COVID, there was no bed for me also. That was the scenario when we all started taking. All doctors, otherwise doctors were not taking, except COVID doctors. Other doctors were not taking. Now all of us are taking HCQ.
Milan bhai, how do you monitor regarding this HCQ prophylaxis, particularly with the ECG? So you said after 2 doses.
So you take the QT interval. If your QT interval is less than 400, you are extremely safe. It is more than 450 QT interval, then you should be cautious and you should repeat ECG.
What is the frequency of ECG? So somebody is taking for more than 2 months or 3 months. So then what is the frequency of doing the ECG?
If you are not taking any other any drugs which can cause hypokalemia, like say you are taking say diuretic or antihypertensive drugs or some phenothiazines and some other drugs, then your QT may prolong. But if you are not any other drug, then you may repeat ECG. I mean ECG after 6 weeks or 8 weeks. That's all. If it is that also fine, then it is fine. But then another thing is delta rise in QTC. So if your QTC was say like 420, and after HCQ it has gone by 60 millisecond or more, then you should be cautious. Then another after dose, another after 48 hours, you take ECG again. And if your ECG, QTC is more than 500, stop it. So 400, below 400 is safe, 400 to 450, just be cautious that your delta, which is 60 milliseconds, is not crossed. And if it is more than 500, don't take.
So,
For
Milan,
me-
but whenever this is true when the antivirals were not available, but we give azithromycin, azithromycin, I'm sorry, we give antivirals, and antivirals are not indicated when the patient is on HCQS. So you have to wait for 24 hours to 48 hours to stop that and then start it. So aren't we missing on in a crucial time of using antiviral?
I personally believe antiviral should be given as soon as possible. Don't wait. See, guidelines, see what is going on in world, USA especially, that remdesivir, if you go to guideline by CDC or NIH guideline or even drug companies guideline, they say that it should be given when patient develops hypoxia or moderate disease, not in mild disease. Huh? So that why it is so, because it is such a costly molecule, but if they approve in everybody, then health cost burden will be so much high for US people that they will not be able to sustain only, because lakhs of people are getting COVID, and if they start giving to everybody and everything is free for the patient, then health burden will be so high. So they made this uh, uh, so that is caveat. So I personally believe that that is not applied in India. All of us are paying from our pocket, or somebody has some health insurance, Mediclaim. So it should be given as soon as you are symptomatic. I personally have seen that it is a wonderful drug. It is useful. Earlier you give, better is the outcome. I've seen fever subsiding, 101-degree fever subsiding in one day. Cough and other things are disappearing in by 80% in one day, 24 to 48 hours. And more the delay you do, sometimes patient takes home care for 6, 7, 8 days. They become slightly more symptomatic. Fever goes on increasing. Then they come on 6, 7, 8 days. Then you give responding, but then effect is not as good as when you start on day 2, 3, 4. First
No, I
7
agree.
days are crucial.
I agree, but the basic question is that what do you do to HCQS? When do you stop it? Supposing I have to use antiviral, should I stop the same day and start antiviral the
They
same
don't
day?
need HCQ if you are taking as a prophylactic or as a therapeutic.
Prophylactic only. What else?
Then there is no need to stop. I mean, we don't bother. Give remdesivir.
Okay, fine. And then the treatment is over, patient is fine, he goes home. When does he start again?
What HCQ?
Yes,
Prophylactic.
yes.
You believe that he has recovered from COVID, proven COVID, then at least even for at least 2-3 months, you may have vacation, you may not give. Ultimately, it is not a very safe drug.
Yeah.
Especially if your age is more than 60, or if you have comorbidity, especially cardiac comorbidity or hypertension, or even diabetes, better to avoid. Old age, cardiovascular disease, hypertension, better to avoid HCQ, especially if left ventricular dysfunction is there.
Then we have to.
Don't give.
There's a lot of patients, right?
Not even a prophylaxis.
Sunil bhai,
Bolo.
it's already 2 hours, so I think
Whatever, sir. Yeah. Whatever you say, sir.
no, it's not.
You are the final. You are the final judge. Whatever you say will stop.
But yeah, because I'm seeing that now participants are also leaving. So now I request Bharat bhai.
Sure.
His last comments.
I think it was a great conversation among the experts of individual fields. All of the experts are, I would not call them Ahmedabad experts, they are India experts. So thanks a lot for sharing on such vast topics. And I'm sure it would have been helpful to all those who have attended. Thanks a lot once again. There are many questions which remain unanswered, and we'll have to have another session considering the time taken. And COVID is such a subject that new things are come up constantly. So we will, if the vaccine is still not available or not effective in another month or so, probably we will be able to have another session somewhere in September or October. Thanks a lot once again.
Yeah, Russia has tested the vaccine, and I think Mr. Putin's daughter has been given today. I
So,
think.
so exactly. So whether it is effective or not, let us see.
No.
Okay.
Thanks once again, everybody. Thanks, Milan Bhai, Dr. Ashish, Dr. Yogesh, Dr. Haribhakti, Asit, Dr. Ankit, Kalpit Bhai, everyone. Thank you, Dr. Viren Bhai.
Thank you.
Thanks. Good night.
Bye bye.
Good night.
Sunil Bhai.
Thanks, Chirag Bhai.
Very
Good
nicely.
night.
Good night. Good night.
Bye.
Thank you,
Thanks,
everyone.
Dr. Nitesh. Thank you.
Thank you, everyone.
Thanks, Sunil Bhai.
No,
Sorry,
thank
you
you,
were
sir. Thank you, sir.
you took the whole trouble of ensuring that everybody was kept under control in terms of the length of the answers. Thank you.
Good, good. Thank you.
Thank
Thank you
you.
so much, sir.
Thanks, everybody.
Bye-bye.
Bye bye.
Best.
Thank you.
Have a healthy life.
Thanks. Same to all of you. Thank you.
Okay, bye-bye.
Bye bye.
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 Bas Pilupati.